We know that there is a lot of research which is going on continuously in the field of pediatric endocrinology across the globe, and a huge number of publications which are there, which happens. But unfortunately, most of those publications do not result in changes in terms of our clinical practice. The reason for that is that we cannot go and look at each and every paper individually. So guidelines are in a way a bridge so that we can look at the current evidence available, and which will tell you whether you need to change your practice or not. And this is what the theme would be. So why do we review guidelines? Is that because this provides us information which is evidence-based. Now, most guidelines are by the leading experts which are there from the group. So today we're going to talk about guidelines which are coming from the International Society of Pediatric Adolescent and Diabetes, the multiple pediatric endocrine societies which postulate the SGA guidelines, as well as the endocrine society. So they are usually evidence-based, and they provide us some perspective as to what is relevant from a clinical perspective, and a huge amount of data is filtered from that regards. We know about what's happening in that particular field, and often it is very difficult to understand, interpret. So this is like something which is made easy for us to not go towards all that literature review, and we go from that perspective. So what basically we are going to do is to basically try to cover the various aspects which are relevant in terms of guidelines and that perspective. All of you can go and have a look at our website, learning.growsociety.in, which provides a lot of information about various aspects of pediatric endocrinology. We've got various courses available which provide insights and other tools for pediatric endocrinology. There are a lot of other activities like journal club, like grand rounds, as well as the lecture series which is there. There are publications as well as the mobile application which can be used from that regards. So today I'll be focusing about 3 specific topics. The first topic which will be taken by me would be on type 2 diabetes guidelines. Then we have Dr. Dhwani, who will be talking about the SGA guidelines by the International Pediatric Endocrine Society Consortium. And then Dr. Dhwani will talk about the gender discordance guidelines via the Endocrine Society, and how do we assess from an endocrine perspective largely from that regards. So as I said, we will try to focus about all this. What is the evidence, what is the state of art, and how we can implement it. So what we have done is that we have used cases to pose specific clinical query where there is a lacunae in terms of current practice, and see what these guidelines change, whether we need to change our management, our assessment, and other aspects on that regards. So when we look at a guideline, we have to particularly look at how much literature they have really reviewed. So that becomes important. Whether they have used a standardized protocol, which is the grading protocol for evidence, which I'll touch base about a bit in the next slide. What weightage is given to individual aspects, and whether there is any particular bias or not. So what guidelines we are talking today are based upon the well-known international bodies which have published so many guidelines. So many of them do not have all these issues. But whenever you are assessing, look at how much literature was reviewed, who were the people involved, whether they were showing any bias in that regards or not. And that's why this grading of evidence becomes extremely important. Now, remember that guidelines are not the all end all as far as clinical practice is concerned. Now, generally, guidelines tend to dictate that this should be done. Now, you should remember that this should be done in an ideal situation. Now, every child is different. Every scenario is different. There are socio-economic, racial, ethnic, so many issues. So we cannot just follow everything which is there on the guideline. We have to adapt them. Second, they do not talk about individualized care. So we have to individualize the management. As I said, more often they are community-based, and often feasibility issues are there. You have some complicated investigation or some very expensive treatment which is available, which you cannot utilize in your patients. So you don't have to really think that, okay, we are doing something wrong. So you have to basically go through the guideline and try to see what you can do within your resources. The type 2 diabetes is a major problem. Globally, in certain areas, we have now more adolescents who present with diabetes who have type 2 versus type 1 diabetes. And we are also seeing an upsurge in that regard. So management of type 2 diabetes has been an area of a lot of active research. A lot of work are coming up, a lot of trials which have now gone through multiple phases have come up. And they've clearly shown that diabetes in children and adolescents is much more aggressive as compared to adults. The loss of beta cells is also much more rapid, and the need for multiple therapies is much more. So we need to think about hit early, hit hard in terms of management of diabetes, and this perspectives have changed over the last decade. So earlier people were saying, okay, you go a bit gradual, you treat to failure. When your sugars are not controlled, you start a medicine. When it's not getting controlled, you start the next step. Now we know that the first year of treatment is very important because of the legacy effect. So a good glycemic control in the initial years has got a lot of benefits which happen subsequently. So now we are shifting from a treat to failure to treat to target approach. So your HbA1c should be below this, your sugar should be below this, and we don't want you to fail. If you are good, if it's too tight, you get down or you step down in terms of treatment, and that's what the major change is. So we'll see what has been the upgrades with regards to the 2022 guidelines from that perspective. So we'll start off with the first scenario. A 12-year-old boy with obesity who is having a BMI of plus 2.2 SDS, so significant obesity, has got acanthosis and a family history of diabetes. This is a run-of-mill presentation that we see day in and out in our endocrine clinic. Now, the question is whether this child requires assessment for the glycemic variability, whether this child needs evaluation for the glycemic status. If yes, which test is the best, and how do we interpret those tests? So this is a big question that we have to answer. Now, if we go via the ISPAD guideline, they clearly show that we should do anybody after 10 years of age or onset of puberty. And this is something which we have also seen. That type 2 diabetes and even pre-diabetes is exceedingly rare before 10 years of age or before puberty. So any obese pubertal boy or girl, we have to evaluate. This is one thing which they have mentioned. And they are talking about even the overweight category. So although we haven't seen many patients in the overweight category who do develop type 2 diabetes, but they also talk about overweight. Now, Dr. Dhwani, what do you think? If we compare somebody who has pre-diabetes versus diabetes, who would have more BMI? Pre-diabetes or diabetes? At presentation. Diabetes. Vibha? It is an interesting loaded question. Why I'm saying at presentation. Often patients with diabetes may have lost weight. So we have seen patients, that's why when you talk about our cutoffs of BMI standard deviation score, we talk about overweight cutoff for type 2 diabetes rather than having a obese cutoff. So because of the loss of weight, it may happen. But so what they're saying, anybody who is overweight should be assessed. So this is an important point to think of. Now, what test they say is fasting glucose, 2-hour value, and HbA1c, the standard guidelines which are there. And if you compare these three tests, and this is based upon our own understanding, is when you talk about fasting hyperglycemia, you mean this child even in the basal state has high sugars. When you have talking about HbA1c, it is the overall mean. So sometimes going down, sometimes going up. And when you talk about after glucose load, this is only when you are eating out. So let's put it this perspective. You wake up in the morning, your sugars are high, that's fasting hyperglycemia. Day to day, your average is high, that's HbA1c. And when you go to a restaurant, eat something, your sugars go up, which is the after glucose load. So which one of these will be the most significant? I think fasting will have a significant implication. If your fasting is high, you need to worry. And this is particularly true, especially for GDM, where fasting hyperglycemia is also given a much more weightage. But they give equal weightage to all three. So if we talk about this, fasting will have the lowest sensitivity, but it will have a high specificity. So what I'm trying to say is that if your fasting is high, you are most likely to have diabetes, but fasting is low, you may still have diabetes. HbA1c has the lowest sensitivity. So many patients with type 2 diabetes may be missed if their HbA1c. So HbA1c below 6.5 does not rule out diabetes. This is an important thing to remember. And glucose load, of course, will have a reasonable sensitivity and specificity. The variability, of course, is much less for fasting because that's a fixed phenomena. You have not eaten anything for 8 hours, your reading will not vary. Now, after glucose load, there are so many other factors which may play. And HbA1c, if you use a very good test, you will have less variability. But that has to be standardized against the DCCT. So this is an important factor to remember. So both of them are for fasting. and HbA1c for screening, while after glucose load is more for confirmation and high suspicion where you do. So most cases of type 1 diabetes, of course, you don't need a glucose tolerance test, but obesity you would need from that regard. Now, very important is that you just not focus on glucose, look at lipids, look at blood pressure, look at ALT, other complications also. You have to look at it, and that becomes important. Now, in this case, fasting is 96, HbA1c is 5.3, and after glucose load, it's 123. So all is normal. So the next question is, what do we do in this obese child who has come to us? So the recommendations are that you don't stop there. You have to follow them up. And after at least 3 years, we would typically do every year, but they have talked about minimum every 3 years is important to do the assessment, and that will become important. Now we have a 16-year-old boy with polyuria who had a blood sugar which is very high, 440. HbA1c is 10%, and there is mild ketosis, no acidosis which is there. Diagnosed as DKA, insulin was given with requirement came down over time, and he also was obese. There was a strong family history of diabetes. There was acanthosis nigricans. So now the treating physician had thought of a possibility that this is actually type 2 diabetes, not type 1 diabetes. So in this scenario, what do you think would be important from that perspective, Dr. Vibha? What do you think? Is this type 2 diabetes? Based upon this information, would you call this type 2 diabetes?
The patient has high accuracy, ketones positive. This patient is behaving more like a type 1, but the insulin
requirement, now he is not requiring any insulin. He is off insulin. As soon as you started metformin, he is off insulin. He is on the obese side. There is a family history. So it is mostly type 2 diabetes. Do you agree with this management? Is there something wrong here?
We should not completely stop.
So what should be done before you stop insulin?
We should go for the GAD antibodies.
So that is the biggest thing to remember. That's a very big message. And if you look at the criteria for type 2 diabetes, what they say is very important. You talk about all that fasting, PP, HbA1c. This line is very important, negative islet autoantibodies. So unless you have excluded a pancreatic autoimmunity, do not label somebody as type 2, because obese type 1 will behave like the same. And if you stop insulin, they will develop DKA later on. So this is again a message which is reiterated very clearly, that if you're diagnosing type 2 diabetes, always consider that our islet set antibodies, GAD antibodies are negative. So this child was GAD positive, insulin should be continued. So this is a message which is now very, very clear, which is coming from the guidelines. Now regarding classification, we already discussed that it based upon various factors. If the onset is before 6 months of age, we talk about neonatal diabetes and genetic testing. If the onset is after 6 months, and if there is DKA and persistent insulin requirement, that is type 1 diabetes. If it's not, then you do a GAD antibody to classify a monogenic form versus the genetic form in that perspective. If after 6 months of age and you don't have any DKA, GAD is positive, it is type 1. Otherwise, based upon obesity, you can classify into type 1 and type 2. So very importantly, GAD antibody comes high up in terms of suspicion before you label anybody as type 2 diabetes. Now, 9-year-old girl with obesity, and in this scenario, she is quite obese. HbA1c is 6.5%. Blood sugar fasting is 90, 2 hours is 120. So your HbA1c is slightly high, but fasting and 2-hour values are not that high. So what do you do if there is a conflicting result between two different parameters? And this is very, very common. Now remember, in this scenario, that HbA1c, as I said, it has got less sensitivity. But if you are not measuring HbA1c using a standardized assay, you would have confusion in terms of making the right diagnosis. So what the guidelines say is that point of care test should definitely be avoided. It should be done via a lab which is validated against the DCCT standard. It is very, very clear. So in this case, repeat HbA1c was normal. So now on follow-up at 1 year, fasting is 128. So we have to follow up. Fasting is 128, 2 hours is 230, and HbA1c is 7.2. So now this patient at that time was not having diabetes has now emerged into diabetes. Now, before we go into that, if there is a discrepancy between parameters, the guidelines basically say is that you repeat the parameters. And in the same test, if two parameters are positive, so let's say fasting is positive and HbA1c is positive, then you take it fine. Or in two tests, in first test, your fasting is high. In the second test, your 2R value was in the diabetes range. You can then assume it to be positive. If only one is positive, do not consider that. However, if there is discrepancy between the two, you consider the one which has a higher value is more significant, because that you don't want to miss diabetes. That's a basic message from that perspective. So now, based upon that, what sort of lifestyle measures should we choose? And most of us are aware about that, but the guidelines talk about very clearly that mainly would be eliminating sugar intake, reducing high fat and calorie intense diet, talk about portion size, meal from outside should be repeated, regular meal, family meal. So general ideas are the same. Physical activity, at least 45 minutes, 3 days a week, reduction in television viewing time and sedentary activity, and very important emphasis on sleep, approximately 8 to 11 hours, depending upon the age of an individual. So these general measures are important, but these general measures are not going to give you a huge reduction in HbA1c. So if your HbA1c is already 7.8, do not rest upon these general measures. So what should be your goal? And that will tell you as to when these general measures may alone be enough. So for goals, what the recent guidelines are very clear. They're talking about absolutely normal levels. Now, Dhwani, what do you think? Is it easier to get good control in type 2 in adolescence or type 1 in adolescence? Which is easier to achieve good control? Yes, because they have good amount of insulin. It's just a resistance, so you will have a good control. But type 1, you can't have the same control in that perspective. So what they're talking about is absolutely normal. Fasting 70 to 110, post-meal 70 to 140, and HbA1c less than 6.5%. So the guidelines clearly talk about very, very strict control as far as these sugars are concerned, and this is usually achievable. Now let's go about, we've talked about lifestyle, we've talked about making a diagnosis, we've talked about the goals. Now, how do we manage that? So we have a 18-year-old girl who basically had a fasting level, which is 188, and 2 hours is 340. HbA1c is pretty high, ketones are present. She is obese with acanthosis. So as I said, at the presentation, you may not know whether this is type 1 or type 2, but then you have to make a decision about how to go forward in terms of management. Her C-peptide is on the higher side and GAD is negative. Now, how would you manage in this scenario, Dr. Vibha?
This is like patient is having high HbA1c, so only the lifestyle modification will not be enough. You have to go for.
So you have to go for pharmacotherapy, definitely. Which pharmacotherapy? Yes. So if somebody is ketotic, I would be very, very wary in starting metformin, because in ketoacidosis, metformin can worsen. So this you have to manage as any type 1/DKA, look at blood gas and everything. And then after 2 to 3 weeks, you start that in that perspective. So if you now look at what the options we have is, we can either decrease the hepatic glucose production using metformin. We can use thiazolidinediones to increase the muscular uptake, which is the PPAR gamma agonist. You can use GLP-1 receptor analogs to decrease gastric emptying, insulin production, decrease glucagon production, and induce satiety in the brain. You can use DPP-4 inhibitors again to prolong the effect of GLP-1. You can use glucosidase inhibitors, which can decrease the glucose absorption from the intestine. You can use the insulin, of course, which is the clear-cut final replacement, or you can use the other parameters. So now, what are the agents which are clearly cleared in adolescence? We all, of course, know that insulin and metformin are the mainstay. And now we have GLP-1 receptor analogs, which are being recommended in a better way in most perspective. So now what the guidelines say is that anybody in which the HbA1c is in a reasonable range. So if your HbA1c is less than 8.5%, you should start with metformin alone as a good therapy. Now, when do we get that sort of figures? Happens when you have a child who comes to you for the first time, you're evaluating for obesity, then you get it done, then you will find it. Anybody who comes to you who is symptomatic, usually the HbA1c is beyond this level. So what I'm trying to say is that in the acute stage, one, you are not sure whether this is type 1 or type 2. And second, your HbA1c levels will be beyond that. So then insulin becomes important. Regarding insulin, they say that if there is ketosis, ketonuria, or acidosis, and A1C above 8.5, insulin is absolutely important. Now, if somebody is in frank decay, they haven't mentioned in as many words. If somebody is in frank decay, start basal bolus. If somebody has mild ketosis like that girl, you may start with a basal insulin because that will supplement the perspective also from that regards. Now, what they say is that once you start insulin, 2 to 6 weeks, you can start thinking of adding metformin. Be wary if there is acidosis. I don't want to start because I can precipitate lactic acidosis. But if you have a good response, 2 to 6 weeks, you start metformin. And we have just seen last week how those two girls responded very well with metformin. And suddenly the requirements will come down and you will know this is type 2. But before that, you should also have the GAD antibody done. So by 2 weeks, you've got those results done. And then you start using that to reduce the insulin requirement. So just to summarize, based upon the guidelines, if there is a non-osmotic symptoms, HbA1c is less than 8.5%, start metformin. If there's improvement, you continue. We have seen that approximately 20 to 30% patients may even come off metformin as well. But all of them, if they do not control their diet, will go back in terms of developing diabetes. If there is no improvement with metformin, in this scenario, now we tend to go more with GLP-1 receptor analog, although basal insulin is also an option. If, however, there is osmotic symptoms, A1C is more than 8.5, but there is no DKA or honk, you can give basal insulin and metformin together, and you can go up to 1.5 unit per kg per day. Then you think of prandial insulin. Insulin therapy without sensitization is difficult because their insulin requirements may become very, very high because of insulin resistance. Now, if there is improvement, you can taper metformin. Here also, you may think of GLP-1 receptor analog as an option if your requirements are very, very high. However, if somebody is DK or honk, you start insulin and then gradually add metformin to see for improvement and then go from that perspective. The guidelines say if your target of 7% at least, so 6.5 is the ideal, 7 is the upper limit, then you think about second line agent, which becomes important. And if your HbA1c becomes worse, more than 10%, consider adding a basal insulin. So these are the general guidelines. So these are the two new parameters that we have talked about. If HbA1c is more than 10% on follow-up, think of a basal insulin. My take would be if you're not responding to metformin, please consider a GLP-1 receptor analog if the patient doesn't have any significant osmotic symptoms on that perspective. So now if we go back to this scenario, we have got a girl who has got ketosis, which is clearly there. So in this scenario, of course, we have to start with a basal insulin and metformin. And she was started on glargine and gradually she responded well to metformin. So this will be the way which we have adapted from the guidelines. Now on follow-up at 12 months, she had poor adherence, now has weight gain, HbA1c is 9.2% and SGPT is high. So steatohepatitis is happening. What do we do here? So as I said, again, we have got this worsening which is happening. So either you go to basal insulin or you think about a GLP-1 receptor analog. And the injectable preparation liraglutide is clearly approved in children from that regards. So metformin was increased and GLP-1 receptor analog, which will reduce weight, will have a beneficial effect on steatohepatitis and will also improve the glycemic control. So this is the way forward from that regard. Now, what about complications? And we know that type 2 diabetes causes huge number of complications, including hypertension, dyslipidemia. For these, you have to measure blood pressure at each visit and lipids at diagnosis and annually. Nephropathy, albuminuria should be done using 3 first morning collections and then you assess from that. Retinopathy at diagnosis and at follow-up. So the big difference between type 2 and type 1 is that 30% children who have type 2 diabetes have one complication or the other at the time of diagnosis. So you have to assess, you don't wait for a long time. Why? Because it's a long-standing disease. It's not just a short-acting disease. Second, after puberty, the complications increase even in type 1. So same will apply here as well. Neuropathy, also food examination becomes important as per the guidelines. Think about PCOD, ask about menstrual history, hirsutism, acne, and other parameters, and always measure steatohepatitis. And I would basically be focusing on these three: hypertension, dyslipidemia, and nephropathy, because these are the ones which we see most common. So blood pressure should be measured at every hospital visit, and we all know that you've got those guidelines based upon which you can classify the various forms of blood pressure. Ideally, they say you can measure it through various options, but if you are using a sort of an automated device, if it's abnormal, measure again via the cuff. And they also talk about the role of ambulatory monitoring if you have doubt about the white coat hypertension. Now, echo, this is a new guideline which says that individuals who have got significant hypertension, you should get an echo to look at a cardiac effect of that hypertension. Initial management, of course, is the nutrition approach, low salt diet, followed by, they talk about monotherapy with ACE inhibitors. If that is not working, you can think about ARBs, you can think about CCBs, calcium channel blockers, and diuretics. So this is the basic sort of a protocol. So blood pressure, you have to monitor at each visit. If it's elevated or stage 1, you mainly focus on salt restriction and lifestyle measures, which becomes important. If there is no improvement, or if you are stage 2 to begin with, start on ACE inhibitors. If there is no improvement, the options are 3: ARBs, thiazide, and CCB. So most of us will be thinking of perindopril, lisinopril, these sort of drugs. We start off from that regards. What about triglycerides? So this again is an important factor with regards to the lipid abnormalities. So now we have got a 16-year-old girl whose cholesterol is 240, LDL is also high, and triglyceride is also high. So now, Vibha, this patient has just been diagnosed with diabetes, and she has been advised statin. Do you agree with that or not?
So we don't advise statin because of triglyceride is
So LDL is 180.
we see what is the non-HDL level.
So LDL is 180, so non-HDL will be high only. So I think the major question you will ask is, how long has she been off the diabetes diagnosis? Has her sugars been controlled or not? So you should not do a lipid profile before they actually achieve a metabolic stabilization. So that's very, very important. So as you said, should be achieved only after glycemic control has been achieved. So do not do a lipid profile at diagnosis. You will get a high reading anyway. And then after 3 months, once you have done that, then you don't wait. So in the initial phase, you will say, okay, lipotoxicity. Like you have glucotoxicity, lipotoxicity is there. But after 3 months, whatever, you can check that. That is the important factor to remember. Now, what they say is that if your levels are above 130 for LDL, you have to start targeting. And HDL, there's no specific treatment for HDL, but less than 35, you are a bit worried. And TG levels more than 400 would be a cause of concern. So this is what you need to understand in terms of their guideline levels on that perspectives. And they say that if you have persistent levels of elevated LDL beyond 130, you should start with a low dose statin. Low dose will be like 10 milligram of atorvastatin and 5 milligram of rosuvastatin, which can then be built up subsequently. The problem is, once you start statin, when to stop? In females, it is a big issue because ultimately it is going to cause a lot of problems in terms of teratogenicity. So you have to be cautious in not starting in everybody with statin. But yes, type 1 diabetes or type 2 diabetes in this young age is in itself a cardiovascular risk factor. You have to consider adding statin at some point. So if your LDL is less than 100, nothing to worry. 100 to 130, go for lifestyle measures. Improvement, you continue. No improvement, then you go ahead with statin. Start with low dose. If there's no improvement, go on higher dose. And if there's no improvement, think of ezetimibe and other group of agents which decrease the gastric absorption also from that perspective. And of course, you have to look at specific guidelines which are there, the child 2 guidelines about cholesterol, fat, and other intake. as well as statin start with a low dose, 5 milligrams of Rosuvastatin, 10 milligram of Atorvastatin, and target LDL below 100. So these are the basic guidelines which are there. Triglyceride is usually going to cause a concern if it's beyond 1000. That is the time when they will cause pancreatitis. But here above 400, you have to consider adding fibrate. Generally, do not combine Rosuvastatin and fibrate in children because both can have hepatic issues. So we have to be cautious in that regard. So that's what they're saying. Statin plus fibrate combination should be preferably avoided. Now, 16-year-old girl diagnosed 2 years ago. Now, urine ACR is 380. What would you do in this scenario, Dhwani? So what could be the possible causes that in this girl, your urine ACR is very high, false positive? Anything especially in girls?
She is obese and she is.
Vibha?
But she is menstruating.
So close to menstruation, your levels will be falsely high. So everything else is normal and suddenly you find this level and parents become really concerned. So what they say is that it should not be only a single reading. You have to do multiple readings to make a diagnosis. And levels, of course, 30 to 300 is significant, in which you need to do a ACE inhibitors, BP control. But beyond 300, you have to think of whether it's really positive or not. But if within 2 years, urine albumin is more than 300, it is not nephropathy. You have to start thinking of alternate possibilities. Somebody having nephrotic syndrome, somebody having whatever. You have to refer to the nephrologist from that perspective. And very importantly, when you have started ACE inhibitor or ARB, you have to look for urine albumin within 6 months. Now, what would you do? Well, suppose you start her on Ramipril. What test would you like to do after how many days to exclude any complications of that drug?
Serum electrolytes to look at hyperkalemia.
Serum electrolyte and creatinine. Sometimes if there is some the blood flow is less, you may cause worsening of renal function, which you have to be aware about. Now, 16-year-old girl with other parameters. Now, what was there that she was having menstruation recently, and that was the cause of false positive cause of that. So this is something you have to be wary about. So not every single reading, don't get too much psyched about from that perspective. Repeat was normal in this regards. Finally, about steatohepatitis, and we have seen in obesity that steatohepatitis is a major problem. So in diabetes also, it becomes a problem. So you have to measure. Now, big issue is that suppose your ALT level is 70 or 80, whether you start metformin or not. Because metformin is known to cause hepatic, and hepatic dysfunction is a contraindication for metformin. So generally, this is because of steatohepatitis, metformin will improve that. So unless the levels are 3 times the upper limit, do not give metformin. So if it's more than 120 or something, then I'll be worried, but otherwise I will not be worried. If they are more than 3 times above, this is what they have said, you have to think of other causes. So you have to refer to a gastroenterologist and do not start metformin in that perspective. And very importantly, this is often people have a question and they have given a very clear-cut answer that if you have NAFLD, does not exclude the use of metformin if your SGPT level is less than 3 times the normal limit. So what they have tried to do is to provide a guideline with regards to the diagnosis, lifestyle interventions, medications, complication assessment. So it's a very comprehensive guideline which are freely available on the ISPAD website. All of you should go and have a look at it. The key takeaways are that we have to start early in terms of treatment. We have to look at HbA1c with a pinch of salt when you look at in terms of diagnostic classification. Metformin remains the mainstay, but there is an emerging role of GLP-1 receptor analog. We should have a low index of treatment threshold for starting insulin, especially in the initial phase, and monitoring for blood pressure, for lipids, for fatty liver, as well as for other complications is absolutely important. You can all go and have a look at our website, our courses which are available, and the mobile application. So